Very pleased today to be speaking with John Smithisler, a healthcare administrator, and he is going to be giving us his perspective on his career as well as the healthcare industry as he has seen it throughout his career. Welcome, and glad to be interviewing you today. How did you get started in healthcare? What in your early years drew you in that direction?
Thanks for having me, Dale, and the opportunity to do this. I appreciate it. What got me started in healthcare was that I lived 7 blocks or grew up 7 blocks from a hospital. And when I left high school, I didn't immediately go to college. I took a year off, and my mother said, well, then you're going to have to get a job. And so the logical place was to go to the hospital and see what was available there. And that's when I started working in housekeeping at the hospital. And so that's what got me started there.
Interesting. And so from there, you went to college and majored in business.
That's correct.
Mm-hmm.
So
Still drawn to healthcare at that point?
yeah, I went to, while I was at Holy Cross Hospital, I happened to know somebody who was running what they called Central Sterile Supply. And for people that have been around for a while, they automatically know what that is. But basically, everything with the exception of pharmaceuticals went through that department. And so after about 3 months in housekeeping, this guy that I was telling you, who was friends of my parents, came by and asked me if I wanted the job there in his department. I said, great, because it was evening shift, which was great because that way I would have the day all to myself. And it paid a evening shift differential, so I made more money. So it was perfect.
Mm-hmm.
That allowed me to see all of the stuff that went through the hospital, and my curiosity got to me because I was thinking, what's this for? What's that for? Why do we use this? How is this used? And learned, a lot. And I was intrigued at that point, but I knew that I wasn't going to get far without a college degree. And so that's when I decided, all right, I'm going to have to go and get a college degree, and then I can come back and see what I can do here at the
Mm-hmm.
hospital. So
Interesting. So your entree into the healthcare system was through infrastructure, logistics, that door.
it was definitely, I, there were a number of people that were around my age that were working in this department. And I think all of us had a natural curiosity about things. And I think it was my curiosity. Plus, it helped that my sister was an OBGYN nurse. My aunt was a nurse who went to Catholic University, ended up becoming an administrator at St. Elizabeth's in DC. So I had that connection to healthcare. Plus, my
Mm-hmm.
sister worked in that same hospital that I worked at. So there was a number of items, because I was in the neighborhood, a number of people that worked there I knew,
Mm-hmm.
so that was good.
Mm-hmm.
So it was all those things together that got my attention.
And you grew up in the DC area?
I did. I was born in Washington, D.C., at a hospital that's no longer there. It merged with a couple of hospitals back in the 60s, I believe it was.
Mm-hmm.
But it was called Garfield Hospital. And then moved out to Washington, to Silver Spring, Maryland from Washington. And yeah, and then grew up in the suburbs of DC in Silver Spring, Maryland.
Hmm. And you went to college in South Dakota.
Yes, quite the traveling gentleman I was. Yeah,
Mm-hmm.
I went to South Dakota because people ask me that all the time. Why South Dakota? Since most people don't know the difference between North and South Dakota, let alone where they are. Um, I told them because I got a scholarship. Um, I went to high school and I took 4 years of Spanish, and I was offered a scholarship in Spanish at this small liberal arts college in Yankton, South Dakota.
Hmm. Very interesting. And so from college, you then moved on to working in the healthcare industry and also pursuing a master's degree.
Yeah, so that's correct. I went to, back home to Maryland and went back to look for a job at this same Holy Cross Hospital in Silver Spring. But this time I was armed with a bachelor's degree. And so I was immediately offered the job as the mailroom clerk.
And this is
So
about 1979, around there.
this was this was around 1977.
Okay. Hmm.
1977. So um, yeah, so I got this job in the mailroom, and I thought, okay, was this a smart move? Because right now I could be making the same thing that I am now if I stayed in my other job in Central Sterile Supply. And I thought, all right, I've got to do something here. So I I knew that in order to move up, I was going to have to get a master's degree because by this time, bachelor's degrees were catching on pretty strongly.
Hmm.
And so the differentiator was going to be, having a master's. So that's when I applied to GW to get a degree in healthcare administration.
Hmm. And
Yeah.
from there.
Well, and from there, I went part-time. So I I graduated in 4 years. I continued to work full-time, and because of my because of my experience in Central Sterile Supply, I was able to get a job in a director role at Columbia Hospital for Women, which was right across Washington Circle from GW, from George Washington University. Um, and yeah, and so at that point, it was just a matter of time.
Hmm.
Um, and So I moved on from there. Once I got my degree, I started putting out feelers um, to hospitals, and
Hmm.
and and I had two choices. One was try to go back to Holy Cross, um, or should I go somewhere else where I could begin to expand my um, experience.
Hmm.
Going to college in South Dakota opened my eyes to a lot of things, culturally, geographically, economically. And I thought perhaps going somewhere else to further my experience would be of value.
Yeah.
So so I began to look at, some hospitals, some larger hospitals, but I knew that I was going to have to start at the bottom of the totem pole in many of those organizations.
Hmm.
Um, but what was becoming a big thing back then in 1981, 82 was for-profit healthcare. It was
Hmm.
just beginning, and HCA was was the one that was really catching on. Um, and so I contacted them because I knew they had a hospital in Virginia. So I contacted them and was asked to interview with the CEO over in Virginia, which I did. He passed my name on to the folks in Nashville. I was asked to come there. So I interviewed there and I was contacted later about an assistant administrator job in a mid-sized hospital in Texas. So that's what really began my career.
Hmm.
Yeah, so I interviewed at HCA, and when I was there, there was something that when people asked my advice about pursuing a job in healthcare, that I tell them this story. I was in Nashville, and I was, I was very naive as to how things worked like this, but they said, okay, so just keep track of all your expenses, and then we'll give you an expense report to fill out. You can give it to us, and we will reimburse you.
Yeah.
And I thought, oh, that's cool. That's neat. So I went to Nashville,
Yeah.
and so I got in there the night before, and the only other time I had flown was going out to South Dakota a couple of times, and that was it. So this was kind of neat. Um, and so I went there, and I got there that night, and I was thinking, here I am. I could go to Ruth's Chris Steakhouse, or I could go to the Spaghetti Factory. And I thought to myself, number one, I really would like to go to the Spaghetti Warehouse because they don't have those back in Maryland, D.C. area. So I went to the Spaghetti Warehouse. It was great. It was wonderful. When I was interviewing the next day, a comment was made to me. Um, we see that you went to Spaghetti Warehouse. I think it was 2 days later. We see that you went to the Spaghetti Warehouse. And I said, yes. I said, is that okay? And they said, yes. Most people go to Ruth's Chris. And I said, really? And yeah, and so that sent a message to them, a subtle one, that this is a guy who thinks about where money is being spent.
Yeah.
And this was a for-profit healthcare system. And
Yeah.
I hadn't given that a thought, but it's sometimes these subtle things. So after the interview, um, and there were some things in that interview, you can edit this out if you want, but you know, that I also thought was intriguing to me. They asked me, um, who was my um, who who was my best motivator? And I told them my peers.
Hmm.
And they said, really? He said, no one said that before. They said it's always like some sports figure or their father or their mother or something. And they said, why did you say that? And I said, because they are the ones who I measure myself against.
Hmm.
Is if they're doing really well, um, then I want to do better.
Hmm.
And that was another thing that they thought was intriguing. And so, they could look at all the things that they wanted on my resume, which wasn't extensive at that point in time. It was mostly
Sure.
education. But they could look at all that and, you know, but it came down to a few interesting answers to them. And so they
Yeah.
they offered me the job
Wow.
in
So
Conroe,
can
Texas.
I want to ask you a couple of questions here. One is you got your master's in healthcare administration at a time of major transition in the
Hmm.
healthcare industry. Uh,
Yeah.
managed care was just coming into place. HMOs were a very new thing. And I am curious as to how well prepared your master's program left you. Did you feel that added value, or was it a credential that mostly got you in the door?
Well, I was an arrogant young kid who thought I knew all the answers anyway. I didn't see the reason um, to have to take a lot of the classes at GW because I thought, well, what's the point? This isn't going
Yeah.
to help you in real life. So, I mean, the answer is, I, looking back on it, yes, it was very valuable to me.
Hmm. Yeah.
Um, it was valuable because it made me aware of things I didn't know about.
Hmm.
It introduced me to people who would later become my colleagues,
Hmm.
which was helpful. Um, but I also think that the experience was as much as anything because I could relate to things in hospitals, and what they were getting a lot back then were people that were going from high school to college to master's degree and then going in to run a hospital that they had never been in before.
Right.
Um, and at that time, it was a couple of years after, or yeah, about a couple of years after that the DRG started to kick in,
Yeah.
with Ronald Reagan. So
So there's
that's
another question here, and that is initially when you did your sort of entry level work, you were working in uh, I believe, a Catholic health system, a not-for-profit health system, and emerging with your master's degree, you moved into a for-profit health system. And the
yes.
question is, you were at very different levels, so your perspective would have been different. But did you can you make any comments about compare and contrast those two environments?
Yeah, yeah, it's a very interesting question because at the beginning, yes, I could definitely see the differences. One, on the for-profit side, they were much more businesslike in their approach to decision making.
Hmm.
You know, they had very clear strategic plans. They had ideas of, the return on investments. They had ideas of staffing levels and things like that. They were much more regimented. But at that time, and also in HCA, which I thought was a tremendous company, looking back all these years,
Hmm.
they they did it within reason because the founders of HCA were physicians. It was his son and father,
Hmm.
and they understood healthcare. I would say that the only difference was in the Catholic system, they weren't quite as regimented. Um, they because there were times when and if I'm taking up too much time, just let me know. But there was an example. I remember one time when I was working in Central Sterile Supply, I went back to get a box of pencils, that we needed to fill out all these sheets and everything of inventory. And the guy told me, um, do you have an empty box? And I went, what? They said, yeah, you need to bring an empty box to show that you need more pencils. I went, what? Wait a minute, what's going on? They said, well, they're trying to cut costs and and all that. And I said, well, if they want to cut costs, they ought to come and talk to the people on the ground. I said, we're the ones that can tell them where they can cut costs. Another lesson that I learned very early on. Um, but anyway, so so they were a little bit looser and less regimented. But later on, that the nonprofit Catholic healthcare system, which I then transitioned back to, were just as tough. Um, I can tell you that some of the nuns that ran some of the systems that they were as tough as those guys in Nashville. They,
Hmm.
because they, they would just do whatever they felt was right and let the chips fall where they may. Um,
Hmm.
so at the beginning, yes, there was a difference, but as the hospitals began to realize they had to become much more financially focused. There wasn't that much difference to the point where the the president of the Daughters of Charity once was asked, how can you justify making, so much money in your system? And she said, no, no margin, no mission. And that was
Hmm.
her. And I thought that's a good way to put it. It doesn't matter whether you're for profit or non for profit. If you don't have a margin, you can't provide the services.
Hmm. Good. So you went from HCA, and what role did you play at HCA?
I was an assistant administrator um, at a hospital in Conroe, Texas, a 166 bed, no, 150 bed. I don't remember
Yeah, yeah.
exactly, but
Mhm.
anyway, assistant administrator there, and yeah, so that's what I did there for a couple of years, and then HCA asked me if I would be willing to go because here I you know was a single guy and they needed people because they were absorbing hospitals, very rapidly. And they needed people to go in to help them transition those hospitals um, to the for-profit system, to their systems and the like. So they asked me to go to New Mexico, to Silver City, New Mexico, on an interim basis. Um, and I did that for about 6 months. Then, no sooner had I gotten back to Texas that they said, could I go to a small hospital in Arkansas, in Mena, Arkansas? And it was, and I said, sure, because I knew it was getting on my resume.
Mhm.
Um, and and it also, again, like, which I really enjoyed, I got to understand the culture in New Mexico. I got to understand what drove their healthcare because it's not always the same from state to state. In Arkansas, the same thing. It was in Mena, Arkansas, right on the border of Oklahoma, and got to see the kind of people who came to the hospital, why they came to the hospital. I mean, this town had one traffic light, and
Mhm.
so those two places I went to, and then I was contacted about going to a small hospital on a permanent role in Georgia, in Sylvester, Georgia, which
Mhm.
was in southern Georgia. I was closer to Tallahassee, Florida than I was to Atlanta. That's how far south I was. So I went there, and and that was a real challenge, compared to the places I've been.
So two questions. One is, can you give me a couple of very quick high-level ideas as to what you mean when you say you got to learn the local culture and how that affected the hospital or the health system? What are there any examples of that you could give right off the bat?
About how the culture.
Hmm. What you learned, what affected you, the way you managed.
Yeah, there was, well, that's one angle of it is how did I manage? There was two things. One, in in one of the hospitals I was in, medium-sized hospital in Louisiana, uh, I remembered when the hospital was being built that they were asked, what do we want as far as waiting areas and everything, and what size of the rooms and everything, because they had cookie cutter. And someone said to me, you've got to have bigger rooms because you just don't have one person visiting these patients. It's usually the whole family.
Okay.
And so that was a cultural thing that happened in New Mexico, um, and Louisiana and in Arkansas. It
Yeah.
tended to happen more in rural areas where it's the whole family that comes.
Yeah.
Uh,
Good point.
and and those doctors um, are much more, involved not only in the patient's life but the community's lives and the whole family's life.
Nice.
Um, so that was one example of culturally
Okay.
how it was different.
And the other question is, I'm hearing that HCA is taking over hospitals as
Hmm.
opposed to building them from scratch.
Yeah, that's
And
right.
so I wonder, this is mid 80s now, I believe. And I wonder if you could give me a sense as to uh, what was moving these hospitals, which I'm guessing were not for profits, to be taken over by HCA? Do you have a sense as to the conditions in the environment that led to that change?
Yeah, HCA was, and I don't recall the specifics, as to exactly what they were buying and how many versus because there weren't that many. There was HAI, I think, was a for-profit at the time. I can't remember whether there was another one or not, but they were strategic about what they were buying and where. They were
Mhm.
strategic so that many of the hospitals that they were buying were in the South. They were in
Right.
Tennessee. But then when they bought another system, it involved a number of hospitals in Texas, and that's why they needed people there. So they would occasionally buy a single hospital, say in Oklahoma and the
Hmm.
like. But as you mentioned earlier, as HMOs and PHOs and the like came into being, they became even more strategic because it was much more advantageous to them financially um, to get hospitals in the same state because they could negotiate insurance, with insurances. They could reduce costs as far as, having a central area for supplies that they could distribute out to all the hospitals. So they were much more strategic. At the beginning, I think um, they they bought this one big hospital or system, and then they bought a couple of big hospitals. And mostly when they bought the big hospitals, it was because of capital. The
Hmm.
hospitals were doing fine, but they didn't have enough money to replace the capital and grow and be competitive against other hospitals. Like in Texas, that was the situation. In South Carolina, that was the situation. In Virginia, they were having to compete against big hospitals in bigger cities. And so they would come in by relatively big hospital, 300, 350 beds, and be able to supply them capital because HCA at that point was, um, you know, for profit, not only for profit, but they were a publicly traded company.
So I think you're drawing my attention to a couple of things. One is that if someone were to watch this interview in the future, they may not appreciate the fact that even to this day, but right along, every provider of healthcare has to negotiate every code with individually with every insurance company. And in a context like that, what we see is that bigger institutions have more negotiating power with insurers than smaller institutions.
Yes.
And and the other is that even in the for-profit world, um, managing a hospital is a low margin business. And so you may have years in which you are a few percent or so to the positive, and years when you're a few percent or so to the negative. And so there is an advantage in the for-profit world of being able to attract investors, develop capital, and infuse cash that may not be available to people who are running a not-for-profit that doesn't have much of a bank account.
That's right. And the other thing to springboard off what you just said is if the hospitals in Florida are doing really well, but the ones in, say, Louisiana are not, then there can be that, like you were saying, transfer of finances from one
Mhm.
place to the other. That's why it always annoyed me when my hospital was doing quite well, which all of them did well because of my management style. But
Mhm.
but the thing that would always annoy me is when they would say, well, our hospitals in Texas aren't doing that well, and so, we need the others to sort of, you know, dig a little bit deeper.
Mhm.
And I would say, no, no, no. they should have to suffer the consequences. They need to dig a little bit deeper, not
Hmm.
me. So I was beginning to reflect on, was I really a team player? Um, and and even though I would go along with them, my first reaction is, let's see how serious they are. You
Uh-huh.
know, how serious my bosses are about cutting.
Yeah.
So
Let
anyway.
them eat spaghetti.
Yes, that's right. Yeah, ask those expense reports. Have them. Send them to me. I'll see whether we'll approve them or not.
Okay. So moving on, you've made a few transitions here, and you're simultaneously, I guess, getting more responsibility in these organizations.
Yeah, so in Georgia it was my first job as a hospital administrator, and the guy who was my boss, who was a wonderful, wonderful guy, he was great, and he ended up running HCA later after the Rick Scott Columbia HCA days, which were, a nightmare for the
Hmm.
company. Um, and I remember he said to me, we were in a CEO meeting of all the hospitals in Georgia that my boss was under. His name was Jack Bovender. And Jack, um, he said, "Hey, I want to make an announcement to everybody. Um, Smithhisler, who's at the smallest hospital in this uh, in this division, is their hospital ran a profit this month." And he said, "We've owned it for 10 years and or whatever the number was, 7 years." And he said, "It's never made a profit." And he
Hmm.
said, "John, I was wondering if you can tell us how you did that." I I said, "Well, if it wasn't for the docs bringing me the patients, I wouldn't have
Hmm.
been able to manage anything." So, it starts with the docs. So,
Hmm.
but anyway, but from Georgia, I was asked to go to Louisiana
Hmm.
and to Lafayette, Louisiana, and it was a hospital that was only 3 years old, and it was on the brink of possibly being closed or sold. Um, and it had two big competitors, Lafayette General, which was a long existing nonprofit hospital, and Our Lady of Lourdes Hospital, which was a nonprofit Catholic facility in southern Louisiana, which is very Catholic um, area of the state. And then they had a women's hospital there as well. And so here I was asked to go in and, say, I was told, do what you can with it because we're thinking about possibly closing it or selling it. And
Hmm.
so that was my first big challenge at a hospital. And we were able to turn it around quite
So, I mean,
successfully.
another thing that's coming up here is that medical technology is changing.
Yes.
Care is moving to the outpatient facility or to the office. Stays are coming down, and so you have capacity being carved out of the system as demand diminishes, and you're in that competitive environment where you sort of have two choices. You cut size of your own institution, or you become competitive and try to take patients from someone else. How did that feel from your perspective?
It was a challenge. There's no doubt about it because length of stay, as you were saying, was being micromanaged because the
Mhm.
DRGs that, we talked about earlier
Right.
were, just saying you're going to get paid this much for this um, diagnosis. And if it goes beyond that, then you're stuck. So length of stay obviously was one way that you could reduce those costs because you're not going to withhold drugs or care or anything else, procedures. So length of stay was one big, and it, you know, it wasn't that difficult for me because when you have the right staff, which I happen to have when I was in Texas as an assistant administrator, I realized that if you've got the right people and you educate them well as to exactly how the system is working and they're good, they can work with the physicians. Um,
Mhm.
and as long as the physicians trusted administration to do the right thing for their patients, then that to me was a winning formula
Mhm.
because we would have meetings with the physicians. We would entice them with lots of nice food and wine and the like to get them to meetings. Because as you know, Dale,
Yes.
physicians never get out of that mode of, oh, free dinner? Okay, I'm there. So um, and so we would just talk to them about what was happening. And we said, look, this is your hospital as much as anybody's. So help us figure out how to do the right thing for your parents, for your patients, and then we'll figure out how to do that. But we'll get you involved in the conversation. That to me was the winning formula on how to turn hospitals around. I've always said it takes about 2 years to get the physicians to really trust a new administration, and I still hold to
Mhm.
that. Um, so it took some time, and it was just a technique where I would say, all right, here's what I'm going to do. I'm going to reduce costs in certain areas where I see we can, and in order to make a budget. Um, However, I'm going to spend money where I think it will help me grow to offset any, additional expenses we have to incur, because salaries are always going to go up. Like you said, capital and the like, is going to
Mhm.
continue to cost more. And so you have those related expenses. So, so working together as a team to me was very important. Having the hospital staff, the medical staff and administration to all work together and getting everyone to just say we're not working against each other. We're working with each other. Um,
About cost accounting within the system, do you feel that hospitals do a good job of cost accounting and knowing how much a service costs to provide? Is that something that was always there? Has it evolved? What are your thoughts?
it's never been from the moment that going back to my first hospital, in Washington, D.C., where I was a department director, I remember asking the treasurer, the CFO of the hospital, if I could get a copy of my budget. And he said, no one's ever asked me for a copy of their budget.
Mhm.
I mean, that's when I first realized, wow, how do people know if they're doing well or not? So to your question about the cost accounting, the problem, unlike manufacturing, where you're making widgets, you
Mhm.
know exactly what it takes to make a widget,
Mhm.
but people aren't widgets. And just because you have an appendectomy depends on whether it's a 24-year-old healthy male versus an
Mhm.
80-year-old female
Mhm.
who comes from a low socioeconomic, background. So it's very difficult to know how much things really cost. We know how much pills cost us.
Mhm.
Um, we know how much IVs cost us. But as far as everything else, we don't know how much, say, an appendectomy cost us because there's just too many human variables in the process. So we can get maybe 75% of the
Mhm.
cost involved, but that 25% varies significantly.
Okay, and so when did you come to Worcester, and what were the circumstances under which you came to Worcester?
So if you want to, imagine a map of the United States. So I went from, like I said, I was in Texas, then I went to Georgia, then I went to Louisiana, then I was asked to go back to Texas again to run two hospitals, which eventually became three. Then I went to Los Angeles to run a big orthopedic hospital. I mean, it was a general hospital, but it was vast majority was orthopedic. And then from there, I came to Worcester. Um, and I came here in 2005 is when I
Okay.
came here. Yeah.
Any history regarding St. Vincent Hospital prior to your arrival? Do you want to paint a picture of, the previous decade or 15 years or so?
Had I'm sorry, say that again. I missed part of that.
Just the setting the context for your coming here when you did. St. Vincent Hospital was undergoing a transition between about 1990 and 2005 when you arrived. Do you have any comments regarding that transition?
Sure. From my perspective, what was going on is at the time that I went out to Los Angeles, the hospital I was at was within a year, less than a year I'd gotten there. I was told the tenant was going to be buying my hospital. And I thought, oh no. And at the same time, St. V's out here was being bought by tenant at the same time. They were part of that same deal.
Hmm.
So I so I left tenant because it was very difficult to work for tenant. They were a very bottom line driven, um, stock price driven company. And I really didn't care for that at all. So I went out and I quit that job and then did consulting for about 6 years. And that's when I was called by um, uh, one of the companies that I had done some consulting with called me and asked me if I wanted to come out to St. V's.
Hmm.
Um, and um, so that's how I got out here. And I also liked it. Well, they liked it also because it was a Catholic hospital and I had worked in Catholic healthcare systems. And um, so, yeah, so there was a lot of things that made sense. It was closer to home. It was closer to DC. I could hop on the train,
Hmm.
to go home. So there were a lot of nice things about it. Plus the fact that, I really came from, a working class, family background, and Worcester's, you know, just, you know,
Felt like
is that
home.
kind of a background. Yeah.
Yeah.
And
Mhm.
so I liked it that way, as well. I liked it from a personal and a professional standpoint.
And when you came, what were your observations regarding the hospital when you first came in?
Well, other than the
And
fact
at
that it
this
was
point, you came in as CEO, right?
yeah, I came in as CEO,
Mhm.
and I mean, then and the guy who was trying to hire me brought me in, and he made sure that I was driven up to that third floor entrance and walked in and saw the atrium, you know. And at that point, anybody who's been in healthcare goes, "Holy God,
Yeah,
what the heck is this?"
yeah.
And and just walk. And plus, it was only at that time 5 years old.
Hmm.
So it was beautiful. It was absolutely beautiful. Um,
If I can interrupt here, just for others who
yeah.
may be listening, there's an architectural peculiarity regarding St. Vincent Hospital. A train runs through it, and as a
Mm.
result, when they designed it, they built what amounts to a little bit of a hill over the tunnel that the train was going to go through, and surrounding this is a huge atrium that goes up several stories. So you have this uh, park-like atmosphere, and that is part of the reason for that peculiarity.
Yeah. Yeah, you're right. They had to figure out how to build over the train tracks. Um, You're right. And that's another thing that I thought was fascinating as well. I said, I hope this doesn't end up being like a horror film of some sort where all of a sudden one day this this train engine comes plowing through, into the atrium. But anyway, we digress. Um, so yeah, so at that point I came to St. V's, and it was having its own challenges as well at the time. Um, UMass Memorial wanted to buy it. Um, but there were several things working against them. The insurance companies didn't want UMass to have the only big hospitals in Central Mass,
Right.
and have negotiating power. Um, the, um, the many of the doctors didn't want to have UMass take it over. Fallon Clinic was very involved with St. Vincent, um,
Mhm.
as well as independent physicians. So there was a number of things going on, but it was having its challenges. Um, so, so I was once again in a situation where I had to look and see, all right, what do we need to do to get things turned around? Um, so that's a gun, unless you have any questions. I was just going to say, and one of the ways that I went about doing that is, number one, I realized that St. V's had been around for, at that time, 100 years, over 100
Yeah.
years,
1893.
1893. And so I knew that it had a culture that had to be revived. It had been lost. And I had worked for Tennant. You may have to edit the things out about Tennant if you so desire, but I had worked for Tennant out in California, and I knew that that wasn't important to them. Culture
Hmm.
wasn't important to them. So I knew that's one of the things we were going to have to focus in on. Um, and what I did was I started to read about St. V's. I started to read about the history, started to read about the hospital on the hill, and realized, that the nuns and the medical staff, and the hospital staff were very close.
Hmm.
I soon realized, and this goes back to my first days in the hospital at Holy Cross, is I knew a bunch of people that worked in that hospital because we all were from around the neighborhood. Same thing was the case with St. V's. you
Hmm.
know, I I had to be very careful who I said what to, because so many of those people at St. V's went to high school together. Some went to college together. So what I did was I began to reinvigorate the culture. That's when, I started up, I said, I want to get all the past presidents of the medical staff. Let's get them up on this wall. Um, and you can explain some of this later, Dale, but they had that history wall,
Yes.
going all along. And I said, we need to get that updated to all the things that we've done over the last 5 to 7 years.
Hmm.
And we started honoring those people. You'll know him better than I. Dr. Grambling was the ED doctor
Hmm.
who ran the ED and was beloved there at St. V's. And so we named the emergency room after Dr. Grambling, which people began to look at it and say, it's becoming like the old St. V's again. We're
Hmm.
starting to appreciate the people who brought it there. And and that's when I found out that the bell from the original St. V's was sitting up on the land up there where the old St. V's was. And so we asked the people that own the land if we could have it, and they said sure. So that's the one that you see in the atrium of the lobby.
Mhm.
So reinvigorating that culture began to send a message to people that we're not here to change this place. This place is solid. We just
Mhm.
need to reinvigorate the way you did things before, and let's figure out how we do it. But I also introduced the realities that like we've been talking about for the last, 45 minutes, and that is, we had to, educate people on what the realities of what was going on in healthcare. But because you build that trust up, it was it was it was easier because they trusted.
Mhm.
They trusted the administration because we were trying to recreate what they knew it could be.
Mhm.
Nothing at
At
the
this
moment.
point, we're getting to the point where you've completed your time at St. Vincent's, and you've done some consulting, you retired, and a lot of volunteer work. Do you want to cover those?
Yeah. Now, before I did the consulting before coming to St. V's, and then I went to Lexington, where I
Hmm.
ran a 6 hospital system. It was a Catholic system. And then from there, I went to Chicago to help with AMITA, another Catholic healthcare system, and it was 9 hospitals in the Chicago area. Um,
Hmm.
but yeah, as far as the volunteer work, um, I've always been, since I was, you know, a, a a young adult, being in the teen club in the parish I was raised, and we were just, raised to with the idea that you should help others, and that was always ingrained in my psyche.
Hmm.
And so when I was at St. V's, um, like for instance, I noticed in the OB department or in the ED, we were seeing a lot of pregnant women coming in there that had no prenatal care, and we were having to transfer them because we didn't have a neonatal ICU. And so I worked with one of the local nonprofit uh, companies, Pernay Family Health Service, to open up some prenatal health clinics.
Right.
And I did that. And this is where a lot of people who are financially driven or have never been in hospitals don't understand. But we opened those up, and they started to question, well, that's a bit of cost involved there. I said, but not nearly as much as us having to take care of those patients in the emergency room until we can find a bed for them. I said,
Hmm.
if we take care of them here, then they can come into our emergency room when they're pregnant. They don't need, a neonatal ICU because they've had prenatal care. And our volume goes up in the OB unit,
Hmm.
which it did, which it did. But after I left, they closed it down. And
Yeah.
so, um, but
Very unfortunate. Yes.
yeah, yeah, it really was. So so when I retired after leaving Chicago, I retired. I came back here because I always kept, a house here, the one that I bought in 2005. And I came back here and started getting involved with St. Anne's pre-medical program.
Hmm.
Um, and I will tell you that um, I I spent the first year doing some really, I won't go into the details, but some really menial work. But
Hmm.
that was fine with me because at the end of the night, a couple of hours, I felt much better than spending an entire day of meetings running St. V's or any place else. You just
Hmm.
feel like you're contributing to something. Um, but
And
you know,
and just to be clear by what you say is when you're there, you're doing whatever needs to be done. And you are not coming in as a provider of healthcare. And so you are moving around that space regarding, making sure that everything is picked up, that things are move from one place to another, you're doing everything that needs to be done.
Yeah. And to this day, because we had a snowstorm, you know, um, was it last week? And, it was one of those messy snowstorms. And I spent at least an hour of the time shoveling, the walkway in, the walkways out, salting, and all that other. Yeah, you do whatever it takes, um, which is, not to retread what we've talked about, but that wasn't uncommon at all for me to do when they were short-staffed back in the emergency room. I would go back there and just ask the nurses, what do you need me to do? They said,
Yeah,
well, some of these patients need pillows. So I would just go up and down to the patients that were in the hallways and ask them,
yeah.
what can I do? I could use a blanket. And I called the director of housekeeping in and said, okay, let's start getting these things. And let's
Hmm.
and and the fact that the CEO of the hospital is going in and doing that, you could sense in the emergency room just everything was lifted because they thought, we're not here by ourselves. He's part of this. He's part of, just trying to help us out. So that to me is very, very powerful. And just thinking about it makes me emotional because I remembered some of those times just visiting patients, you know, just visiting patients, which I do at St. Anne's, when patients are waiting, I'll go out and talk to them,
Hmm.
just so they know they're just not a number. And when people come back a couple of times for follow-ups or whatever, and I can call them by name, you know, they, they just go, wow, this is
That's a
great.
human connection. Yes.
It's a human connection. And that's why when, they talk about, doing some marketing, I said, I don't think we have that problem here. People come here because they like it, um, because they're treated well.
Yeah.
Um, so anyway, but yeah, from there, St. Anne's became very busy. And I think part of it is because we had great volunteers great volunteers. And I think because the medical director, Jane Lockery, the executive director, Lisa Izzo, we all shared a common, that was a philosophy of treating people with respect and dignity. And we made sure that that trickled down to all the volunteers. They could see me getting water for the patients who have been waiting in line because it was just very busy that night.
Hmm.
They saw me picking up trash from the floor that someone had dropped because it just didn't belong there. They saw, all of us, wiping off the tables, to make sure that they were clean for this. So it just caused people, the volunteers, and we get volunteers quite a bit. We have to turn them away. Um, and patients who, God love them, that say, is there something I can give? And they said, I would say, do you know another language? And they'd say, yes. I said, can you come and help us with
Hmm.
that? And they do. It really creates a family there. And so we became very busy. And in 2019, we're open from 6 to 8. We're usually there later, like sometimes until 10 o'clock, seeing all the last patients. Um, but there was a night that we saw 129 patients. Now think about that.
In what
Three
period of time?
from 6, and we were there till around 10:30.
Okay, so 4.5 hours.
4.5 hours, and we had, you know, we it, we got it done because we had the right mix of physicians, but also back then, probably 60% of our volume, maybe 65% of our volume, the patient spoke English, but not now.
Hmm.
It's easily as much equally between English, Portuguese, and Spanish. Um, but so we began to look when we saw that. I just said to Lisa and and to Jane that we we didn't have any more room. We either were going to have to start turning away patients or find another place for them to go in addition to St. Anne's. And that's when, being an administrator, I always want to know about data. And so I've been keeping track of data since 2018, and I knew where our patients were coming from by zip code. And about 35% of the patients were coming from the 0160 fill in the blank or 01610
Worcester. Yep.
Worcester, downtown. Um, so I talked to the bishop um, in the Diocese of Worcester and Bishop McManus, and he, wholeheartedly agreed to help us find a place. And so we ended up at St. Peter's, where Monsignor Scollin had been there for, I don't know, 40 years. And so he was open arms saying, yeah, we can start one here. And that's where we started St. Peter's as well. So between Lisa and uh, Jane and myself, we were basically running St. Anne's and opening St. Peter's, and then both of them were open, and both of them are still open today.
Wonderful. So we've covered an awful lot of ground. We
Yeah,
started off talking about your college education, talking about your initial experience in healthcare institutions, starting right at Central Sterilization, and um, and I think your initial observation that good management comes from asking the people who are doing the work what
yeah,
can be done better, and then you've drawn a picture of your many years of providing administrative services to a variety of healthcare systems, including St. Vincent's and Worcester, and finishing off really with the idea that the answers to a lot of administrative problems lie with looking at the people who are doing the work and pitching
mhm,
it at that level and connecting with those people who are providing the services. So a great way to summarize your career. Thank you.
yeah. All right. You're welcome. Thank you.